Hi, and welcome everyone, and thanks for joining so timely. Some people are still trickling in. We will just go ahead and get started with the agenda and housekeeping rules already. So my name is Laura Boonstapel, and I'm a program director at ThinkWell for our immunization economics work. And this covers a lot of work around the cost of delivering vaccines, but we also run the Immunization Economics Community of Practice. And it's as a part of that we're organizing this webinar today. So for those of you who are not familiar with it, the Immunization Economics Community of Practice is a community with over 3,500 members from different backgrounds. So we have people from academia, but also immunization managers, implementing partners, donors, advocacy groups, private sector people, and so on, who share an interest in the generation and use of economic evidence to support immunization programs in low and middle income countries. And so if you're not a member yet, you can sign up. It's free on our website, immunizationeconomics.org. And that way you'll receive our newsletter and you can submit your own news and publications and job and funding opportunities and events in this area of work. And you'll also stay updated on our future webinars as well. Because today's webinar's topic, it's been picked from a survey among our members, and it's the first in a series of webinars that we're going to be running over the coming months. So over to our agenda for today. Next slide. So we have an exciting topic for today's webinar. We'll start off with a presentation by my colleague Flavia Moy, who has led our latest update of the Immunization Delivery Cost Catalogue, and she will explain the purpose and the contents of this very useful database and what we saw when we summarized the evidence base. And because we wanted to showcase how you can use this useful tool in your own work, we've invited three presenters to talk about three very different analyses that they've been working on, for which they have used evidence from the Immunization Delivery Cost Catalogue. So we'll first have Charles Okafor from the University of Queensland, and he will be presenting on the cost of introducing rotavirus vaccine in Nigeria. And after that, we'll have George Gotsadze from Curatio International present projections of the cost and financing of adult vaccination programs in Asia and the Pacific. And then last but not least, we'll have Zin Marwin present her equity assessment of childhood immunization at national and subnational levels in Myanmar. And so we'll first run through all four of the presentations, and then after that, we'll have a Q&A session after all of them, which will be moderated by my colleague, Christina Banks. And so now I'm going to be handing over to her to walk us through some of the housekeeping rules and how you can ask your questions to our presenter. So thanks. Over to you, Christina.
Thank you, Laura. So just a few quick housekeeping points. This webinar will be recorded, and we'll be sharing the recording and the presentations from this webinar via email and also on our website, so you keep an eye on that. Please keep yourself muted during these presentations, but feel free to introduce yourself in the chat. That function is at the bottom of the screen, and you can also ask questions using the Q&A function. So as Laura said, the moderated discussion will be at the end, but feel free to ask questions at any point. And with that, I'll introduce you to our first speaker. So Flavia Moy is a senior technical advisor at ThinkWell Switzerland, where she supports the immunization economics portfolio and led the latest update of the Immunization Delivery Cost Catalogue. In her role at ThinkWell, she has worked on several costing studies, evaluations, and assessments in low and middle income countries, including a multi-country study on the cost of delivering COVID-19 vaccines. So over to you, Flavia.
Thank you, Christina, for the introduction. So today I'm going to present about the updated Immunization Delivery Cost Catalogue, which ThinkWell released in June of this year. In my presentation, I will explain what the Immunization Delivery Cost Catalogue, or IDCC for short, what that is. We will look at what evidence is in the IDCC and what evidence gaps remain. Then I will show you some of the findings from our analysis of the cost catalogue. And finally, we'll go over how you can use the cost catalogue yourself and some example of how it has been used so far. So what is the Immunization Delivery Cost Catalogue? The IDCC is the most comprehensive, current, and standardized database on the cost of delivering vaccines in low and middle income countries. It was first developed by ThinkWell in 2017, and it has been updated 3 times since then, most recently this past summer. So the IDCC is based on a systematic review of over 22,000 publications, including peer-reviewed articles and grade literature. In the review, we looked for publications that included immunization delivery costs from low and middle income countries, and most importantly, that were based on primary data. So that means we excluded publications where findings were purely based on modeling of secondary data. We found a total of 119 publications matching our inclusion criteria. And from these, we extracted 1,156 delivery unit costs, including cost per dose, per target population, and per fully vaccinated person. So what is inside the cost catalog? Besides the unit cost I just mentioned, which in the catalog are included both in the original currency year as well as standardized to 2022 US dollars, the IDCC contains a lot of contextual information to help you understand what those unit costs represent. So this includes, for example, information on the country and the setting where the study was implemented, what was the target population of the vaccine being delivered, what antigens were delivered, how were the vaccines delivered, so whether it was through routine or a campaign, whether the vaccines were delivered at health facilities or through outreach or at temporary sites, etc. The cost catalog also provides details on what cost categories are included in this estimated unit costs. So it specifies whether the cost estimates include things like salaries of health staff, cold chain costs, transport costs, volunteer labor per diem, etc. And the IDCC also tells you what type of cost each unit cost in the catalog represents. So whether they're financial costs, economic costs, whether only startup or recurrent costs or both were included, and whether the costs are full or incremental. So I should mention that, as you can probably understand from the screenshot, the IDCC is essentially an Excel file, a simple Excel file that is fully editable and where you can easily filter for all of the variables that I just mentioned. So if you're looking for evidence from a specific country, you can just go to the country column and filter for that country. Or if you're looking for evidence about OCV campaigns, you can go to the antigen column and filter for OCV, and then go to the routine versus SIA column and filter to only show supplementary immunization activities. So what does the IDCC tell us about the state of the evidence on the cost of delivering immunization services? First of all, the cost catalog includes immunization delivery cost evidence from 49 countries, mostly from Africa and Asia. And these countries represent just 36% of all LMICs and about half of Gavi-eligible countries. So this means that there is no evidence for 28 Gavi-eligible countries and for 86 low and middle income countries. Most of the cost evidence included in the cost catalog is for routine delivery, while 20% is for supplementary immunization activities, and the remaining 7% is for cost estimates that combine both routine and supplementary immunization activities. While the availability of cost evidence on supplementary immunization activity improved a lot in recent years, there is still very little evidence for the different types of SIAs, such as subnational campaigns or integrated campaigns or outbreak responses. So most of the evidence in the IDCC is not strategy specific, meaning that most cost estimates reflect the combined cost of delivering through more than one strategy. So for example, delivering both at health facilities and at temporary sites, or both at health facilities and through routine outreach. This can be the case, for example, when reporting about doses delivered is not disaggregated at vaccination sites by where the vaccination took place. So the researchers really don't have a way to to estimate how much each of the strategies costed on a per dose basis. So the lack of disaggregated data also means that very few studies present separate unit costs for more than one delivery strategies, which would allow for evaluating the comparative cost efficiency of using different strategies within the same context. When we look only at strategy-specific evidence, as you can see in the graph, most of the cost estimates are for facility-based delivery. In terms of target populations, we can see that most of the evidence in the IDCC is for delivering vaccines to children through routine childhood immunization programs, while there is very little or no evidence for specific target populations, like zero-dose children, the elderly, or pregnant women. When looking at evidence for the delivery of a single vaccines, we can see that most evidence is for new vaccines, like HPV, COVID-19, and malaria. And this is partly because newer studies publish more granular cost estimates, and some are more likely to disaggregate by strategy, delivery periods, and more. And so they just generate more data points. However, more evidence is still needed on the cost of scaled up delivery of malaria vaccines, on the cost of delivering PCV vaccines to adults, for which there is currently no evidence at all. And then more evidence is needed on delivering new vaccines approved in the latest Gavi vaccine investment strategy. While there is some model evidence for some of these vaccines, there is currently no evidence based on primary data. So what does the IDCC tell us about what it costs to deliver vaccines in low and middle income countries? First of all, let me explain what this graph is showing a little bit. So this graph shows delivery cost per dose for routine and supplementary immunization activities, with the full gray dots representing the median cost per dose, and the dots with the gray borders showing the minimum and maximum value of each range. So each dot in the graph represents a unit cost found in the IDCC, and multiple dots might be from the same study. If, for example, a study reported one cost per dose for routine facility-based delivery and another cost per dose for routine outreach, then those two unit costs will show up as two separate dots on this graph. I should also add that this graph, as well as the ones I'm going to show in the next few slides, they only represent a subset of what's in the IDCC for each of these topics, because we excluded some data points to increase comparability. So when looking at financial cost per dose for routine and supplementary immunization activities, we can see that routine delivery is usually more costly on a per dose basis. And this holds true also when looking at economic costs. However, we need to keep in mind that the SIA category includes a wide range of activities, such as catch-up campaigns, outbreak responses, etc. And with more data points available, if we could disaggregate further, it could be that some types of SIAs, for example, outbreak campaigns that take place during an epidemic, they could turn out to be more costly than routine on average. So on this slide, we can see the economic and financial cost per dose for different delivery strategies, with the yellow dots representing economic cost and the green dots representing financial costs. As you can see, outreach delivery is the costliest among all strategies, while facility-based delivery tends to be the least costly on a per dose basis. This makes sense, as non-facility-based strategies usually entail things like transport costs, per diem costs, and among them, outreach is usually the most costly because it covers larger distances or might be done in less densely populated areas or harder to reach area, which are usually costlier to reach on a per dose basis. When looking at the cost per dose for routine delivery across target populations, we can see that in general, targeting adults is more costly than reaching children. While there are not a lot of data points for some of these target populations, this graph shows us that specific adult populations, like women of reproductive age and the COVID-19 priority populations, which mostly included the elderly, health workers, and people with comorbidities, these are the costliest to reach among all the target populations represented in the IDCC. And here I want to flag the general population older than 18 target, which is the fifth line from the top. This range includes many data points from COVID-19 that are pushing the median down because during COVID-19 vaccine rollout, many countries were able to achieve very high delivery volumes and those deliver at a very low cost per dose. So this slide shows the economic and financial cost per dose for single vaccine delivery. And differently from the previous slides, here we're including both routine and supplementary immunization activities. What we can see here is that in general, vaccines targeting adolescents, adults, and priority groups are costlier to deliver per dose. You can see that the three costliest at the bottom of the graph are influenza vaccines, which usually target the elderly and health workers, HPV vaccines, which are delivered to preteens and adolescents, and TT or TD vaccines, which are for women of reproductive age. You can also notice in this graph that the cost range for COVID-19 vaccines is quite wide, and that is because this range includes data point for different delivery strategies and different delivery periods, like the initial low volume rollout period and then the later higher volume period, which had very, very different cost per doses. So how can you use the IDCC? First of all, the IDCC can provide useful insights to a wide range of immunization stakeholders. Immunization managers and policymakers might use it to plan and budget for immunization programs, campaigns, or new vaccines introductions, and to develop national financing strategies, for example. The IDCC can also be used by researchers, advocacy groups, donors, and other partners to develop investment cases, cost of inaction analysis, or other analysis to inform resource mobilization and advocacy more broadly. And manufacturers might use data from the IDCC to model delivery costs for new vaccines that are still in the pipeline. So we're about to go over some very interesting examples of how the cost catalog was used in the following presentation, so I won't talk much about that. But I just wanted to show that here at the bottom, you can see some additional examples of how it has been used. And these range from Alison's Portnoy's paper that used the IDCC to generate standardized unit cost estimates for LMICs for which there is no cost evidence yet, to many more analyses, including cost effectiveness and cost benefit analysis, both at country level and across multiple countries. So that's it for my presentation. Thank you so much for your attention. And if you want to know more about the IDCC, you can find the dedicated page on immunizationeconomics.org, or you can reach out to me via email. Thank you.
Great. Thank you so much, Flavia. And thank you to everyone who's saying hello in the chat. It's great to see where everyone's watching from today. So our next speaker, Charles Okafor, is a postdoctoral research fellow at the Centre for Health Research at the University of Queensland. He is a health economist with a background in pharmacy and has an interest and expertise in trial-based economic evaluation and decision analytic modeling. He has a passion for innovative and creative research and desires to improve people's quality of life by providing scientific evidence that will inform decision making. Over to you, Charles.
All right, thanks, Christina. Hi, everyone. So once again, my name is Charles Okafor. So today I'll be sharing with you all one application of the IDCC, and this was applied in the introduction of rotavirus vaccine in Nigeria. This project was carried out in 2021, and the outcome of this study was published in 2021. So the aim of this study is to inform the decisions of health policymakers in Nigeria regarding the cost, the benefit, and implication of introducing the rotavirus vaccine into the National Immunization Program. As we all may know, Nigeria is the highest populated country in Africa. So whatever wrong decision that is made in terms of implementation or delivery could actually mean a lot of costs, not just to Nigeria, but to the international community. So as of 2021, Nigeria have not introduced this vaccine, but it was introduced 2022. So just about less than a year after this study was carried out. And I would like to share that the Gavi, the Vaccine Alliance, have approved the extension of the transition period for Nigeria up to 2028. So Nigeria is one of the few countries in Africa that's are in a very, I would say, unique phase in terms of the Gavi funding profile. Nigeria was supposed to have transitioned to the fully self-funding phase, but due to some challenges, we are still currently in the accelerated phase 2. But after 2028, Nigeria will be funding, hopefully, their vaccines by themselves. So there is actually a transition phase, the co-financing, across these years up to this point. So I won't want to go details into that. So in this model, we're looking at three different vaccines: the Rotarix, the Rotavax, and the Rotacil. And this model evaluated these three vaccines over a period of 10 years. And we collected data from the Institute of Health Metrics and Evaluation, IDCC systematic review, WHO, and also from UNICEF websites. Next slide. So looking at the results of this study, we can $2.66 for Rotarix, down to 1.89 for Rotacil, and we can see that the immunization delivery cost also varies. We can see that Rotarix is the most cost effective with and in terms of the immunization, the vaccination program cost, the cost for the 10-year period was about 210 million, which we can see across the different vaccines. And the study also showed that Rotarix was the most cost-effective vaccine to use from 20.
Charles, are you still there? I believe we lost Charles. Shall we give him a moment to reconnect and otherwise move on to the next presentation? Charles, can you hear us?
You?
We can hear you again. Maybe keep your video off and then maybe the connection will be a bit better. Thanks. I think we've now lost him altogether. Maybe let's move on to the next presentation, shall we?
Sure. So our next speaker, Professor George Gotsadze, is the founder and president of the Curatio International Foundation, a not-for-profit Georgian research institution that works on health policy and systems issues in Eastern Europe, Central Asian countries, and globally. Professor Gotsadze brings over 30 years of experience and expertise in health systems, policy, health financing issues, and evaluative work. He is an associate professor at the School of Natural Sciences and Medicine at Ilias State University, Georgia, where he co-leads the Public Health and Policy Graduate Program. Over to yourself, George.
Thank you, Christina. Thank you, Laura, for inviting, and hello, everybody. I'm going to present the work that we did for Asian Development Bank, who wanted to look at potential fiscal pressure that the adult vaccination program, along with COVID vaccination, would impose on national financing in 40 different countries. Next slide, please. And please click one more time if possible. So we had largely like two objectives for our work. Of course, like this was a time-constrained assignment, as usually happens in the global health field, and resource-constrained environment. So to look at 40 countries that ADB supports through its loan programs, they wanted to look at what is the cost that adult vaccination would require and what fiscal pressure it could impose to national financing. So next slide, please. To deal with these two questions, we had to cover 40 countries. We had to evaluate all WHO recommended vaccines that countries have either adopted in their national strategy or were planning to introduce, and also evaluate the granularity of these plans in terms to identify the target population, the vaccine dosages, schedules, etc. We had to estimate the cost of vaccine. We have to estimate the cost of vaccines itself, inclusive of wastage rates, auxiliary supply cost, as well as vaccine delivery cost, where we did use not necessarily IDCC, but we used the study that Flavia mentioned in her presentation by Portnoy, who has modeled and estimated. So our temporal coverage was 5 years, so cost estimates had to cover 5 years. And as I've already said, we had to look at fiscal impact imposed on national financing. Next slide, please. So how we embarked on our work, specifically, we had to search and find in a publicly available space all the policy decisions and strategies that these 40 countries has with regards to WHO recommended adult vaccines, including COVID, and that was necessary to, as I've said, to estimate the target population groups, their sizes in each country, as well as the schedules that were considered. This information was necessary to quantify the vaccine requirements, as well as to estimate the planned doses that need to be delivered in each country. Of course, we have not dwindled around like different delivery strategies because of the size and volume of the work, and most estimates were based on national strategies, which mostly considered facility-based delivery. And then we had to delve in with regards to the unit cost, separating like the cost of vaccines and vaccine supplies as along with the health system of delivery cost. And then we had to bring all this data together and model in order to estimate the fiscal impact. And of course, macroeconomic and public financing data was sourced from publicly available sources. Next slide, please. So going deeper, what exactly we did. So we specifically looked at vaccine prices using WHO Vaccine Market Intelligence Database, which holds at that time, as I've said, like the work started in 2021 and was accomplished like within 6 months in 2022. And we'll look at income group specific mean prices, because we found that through regression analysis that the prices variability was more linked to income groups as opposed to regional differences. Next, we had to analyze the COVID vaccine. At that time, the UNICEF database only held like 99 records. And we had to exclude China and India as main producers, as well as consumers in our sample of countries, because obviously like their prices for vaccines in India and China would have been different that were reported in UNICEF database. We had to look at the supply cost, like the syringes and safety boxes for which UNICEF databases were used. And as I've said, instead of modeling, we used the published data in 2020, which was based on IDCC database and modeled for those countries, as Flavia said, that had no actual research conducted. Next slide, please. So these were the cost elements that we looked at to compile and arrive to the program costs for adult vaccination. And of course, we established like 95 confidence intervals to then run the sensitivity analysis for our estimates. Next slide, please. These are our results. So the first, you would see that across 14 countries, there was a marked variation in the average cost per capita. Yes, while we use cost per dose delivered as a basis for estimation, we had to convert that into a per capita terms to be more appealing and understandable for the ministers of finance, who are the prime clients for the ADB for such discussions. Therefore, like my presentation includes converted cost per capita. And as you see, the variability was huge, largely driven by factors such as disease coverage, the population coverage targets reflected in national strategies, such as COVID vaccine policies with regards to the booster doses and primary doses. And also due to the high delivery cost, especially in small island states in the Pacific. But median and mean prices are reflected on the chart. And next slide, please. And then we unpacked this cost by antigen to see who was the major contributor. Not surprisingly, COVID was the largest one because of the largest coverage of the population, as well as the pricing that was attached to the vaccines when they were introduced. And we're speaking here probably prices from end of 2020 and beginning of 2021. So before they moderated thereafter. Next slide, please. So we also unpacked the cost by cost categories. And as you would notice, like the largest contributor to these costs, programmatic costs were like the vaccine-related costs and then vaccine supplies. And in over 50% of countries, immunization program cost was largely occupied by these two categories. Next slide, please. What was the impact? You see that the impact was rather significant. So it was as low as 0.1% on general government health expenditure in Thailand to increasing like health budget by 1.3%, 7% in Myanmar. And COVID was the largest contributor. And overall, like these adult immunization programs, we're not considering here routine immunization, childhood immunization. So on top of the immunization programs, for some countries, that was very significant and to a degree not affordable to deliver at a scale, which was originally suggested in their COVID or other adult vaccination policies. Next slide, please. So this work has been published with some delay because production took some time, as it usually does in 2023. This is a technical report of the Asian Development Bank, and here's the quotation. So if you want to see more details, you could take a picture of the screen and you could visit and read this paper. Thank you so much, and over to you, Christina.
Great, thank you so much, George. So we're going to go back to where we left off with Charles to see if his connection is a bit better now. Charles, can you hear us?
Yeah, very well. Thanks.
Great, take it away.
All right. Sorry for the trouble. So yeah, back to what I was saying. So looking at the results, we found that Rotarix was the optimal choice to introduce for about 7 years. And then beyond 2027, it's preferably to go with Rotavac. So, but it's really going to be challenging to do that, which we're going to see later. So if we go with Rotarix and then switch to Rotavac after 7 years, where the country is going to save about 2.7 million. The study also showed that the total rotavirus gastroenterology related deaths that the vaccine will avert over the 10 years period is about 200,000 cases, which is about 20,000 deaths per year. And in terms of the net budget, this is going to be about 76 million naira. And also the benefit cost ratio looks similar across the three vaccines, with Rotarix having the optimal. Now, there is something very important with these results, which we need to take note. Most of the time, the results you get from an economic evaluation really has to do with, the data you input. So one of the cost drivers why Rotavac wasn't the optimal choice for the first 7 years was because of the vaccine wastage. So Rotavac has a very high vaccine wastage of about 50%. So we did a scenario analysis if the vaccine wastage is reduced by 50% of what it's supposed to be. And we can see here in the graph that Rotavac is very likely going to be cost effective from about 2023 to 2024 and beyond. So this tells us that if the country can actually consider reducing wastage and consider other factors, Rotavac can become the optimal choice, because what the country introduced was the Rotavac and not Rotarix, and there are very good reasons for that. Next slide, please. So here is the big question of the day. How was the immunization delivery costs estimated? Next slide. So we estimated the immunization delivery cost using a mapping approach. And this mapping approach includes different variables, including the vaccine. And under the vaccine, we have things like the volume per dose, the volume per fully immunized child, and the number of doses. So for instance, Rotarix has 2 doses, while Rotavax has 3 doses. And we also looked at other covariates like the country income level, whether it's a lower middle income country or a low income country. We also looked at the target population of the vaccine coverage. For instance, Nigeria has a coverage of 49% today. As at the time of this study, it was 57%. And while Ghana used to be 90, and then it dropped to 64%. And we can also see the other the values for Bangladesh and Moldova. Then also another covariate we looked at was the perspective of the costing, whether it is economic or financial. And we can see below the cost of the vaccine for Moldova, which is about 2.46 compared to Ghana, which is 0.9 for a dose. But for Moldova, this is for the full dose of Rotarix, 2 doses to a child, while the cost here for Ghana is 0.9 for a child. So we can see that this cost looks very different, and this tells us the effects of what these variables are playing. Next slide, please. So here is a summary of the weighting system we use. So looking at the figure on the right-hand side, we can see the variables and the cost domain, and you can see how we did the mapping. So we can see things like the paid human resources has some connections with the number of doses. So what this is saying is that the number of doses has an impact on the money you're going to pay to the human resources who are going to administer the vaccine. If you have 3 doses, then you're going to spend more money to vaccinate. And we can also see the other cost domains, how they connect to the different variables. And that was how we arrived at the weighting system. So we were able to estimate unit weight for each of the variables. We can see for the volume per dose has a weight of 0.05. And we can see the level of the weighting. So the levels we can see here is 5 levels for volume. We have 3 levels for the volume per fully immunized child, and for the income level it has 4 levels. So what this level is trying to tell us is like the categories like we have. For instance, for countries that are low income country, that is level 1. lower middle income country level 2, upper middle income country level 3, and high income country level 4. So for the volume per dose, 0.5 is level 1, 1 mil level 2, 1.5 level 3, like that. So that's how we got those levels. So we can see the reference countries we used. We used Ghana and Moldova. So Ghana has that did the health facility delivery, and I think they also did some they did the facility level, and they also did the uh, pilots costing. So what we used here was the facility level. So we can see here that for Ghana, the weighting we got was 1.85 using this weight system. And for Moldova, the weight is 1.5. So if you apply these units and the levels to the weighting for these two reference countries, we can see the variation. And we can see here how the costs for Moldova varies from the cost for Ghana. So these costs were adjusted to 2019 US dollars. So, and we use this result, the weighting, to apply that for the Nigerian setting. And what we got for Nigeria was 2.357 for Rotarix and 2.09 weight for the Rotavac. And we can see the approximated cost for Rotavac was 2.4, and why that for Rotarix is 2.12. Next slide, please. So I would encourage you for more details regarding the study. These are the two published studies we have. The first study actually was focused on Nigeria, while the other study looked at 8 other countries in Africa that are yet to introduce the vaccine, because at the time of this study, there were 9 countries that were yet to introduce the vaccine. So we just had to split the two because the case of Nigeria was a bit complicated. So we did that separately from the other countries in Africa. Next slide. So that's that's it. Thank you.
Great, thank you so much, Charles. So our final speaker, Zinmar Win, is a research specialist in the Research and Policy Unit at Community Partners International, Thailand, and is carrying out health economic related research and her PhD at Mahidol University. Her main research interest is using available healthcare resources efficiently and effectively, and to provide basic healthcare equally to everyone who is in need, regardless of their background. Over to you.
Hello everyone. My name is Sema Wen, and today I'm going to talk about how we use the vaccine delivery cost from the IDCC in our study, equity assessment of childhood immunization at national and subnational level in Myanmar. We use the benefit incidence analysis. Next slide, please. The Myanmar is a conflict-affected, geographically and ethnically diverse, lower middle-income country. The EPI, Expanded Program on Immunization, aims to improve access to the immunization service and to provide the equitable services to the target population. The EPI is currently funded by the donors and government. And we did this study to assess if EPI has promoted equitable access to immunization service for children across different socioeconomic groups. And this study objectives is also related to the donor exit. And Myanmar is now lower middle income country. The donors are preparing to exit. So this study, the findings from this study will help identify the population groups who would be vulnerable to the donor exit. And next slide, please. And in this study, we use the basic immunization service as a measurement of healthcare service use. And the 1 dose of BCG and measles, 3 doses of DPT and polio, these uptakes across different socioeconomic status were collected from the Myanmar Demographic Household Survey. And the vaccine and syringe costs were obtained from the cost of vaccinating a child published by the UNICEF. That will be the same across the country. The vaccine delivery cost, we obtain it from the IDCC, Immunization Delivery Cost Catalogue, and we adjusted the average vaccine delivery cost with the regional and urban rural cost variation for the Myanmar. So that will be different across the country. And we use the benefit distribution, benefit analysis, incidence analysis, and we calculated the benefit distribution by multiplying the immunization uptake and unit cost per dose for each vaccine. That will be different by region, states, and urban and rural area. And we estimated the concentration curve and concentration indices to measure the distribution of benefits across socioeconomic groups, like different wealth quantiles and mothers' education level. And next slide, please. Our findings show that the wealthier families benefited more from the EPI program. In Myanmar, the BCG had the highest coverage and the almost equal benefit distribution. The DBT has the lowest coverage and most unequal distribution. The red numbers here show the concentration indices comparing the utilization and benefits. The utilization had pro-rich distribution for all vaccine. The benefit had pro-poor distribution for BCG and pro-rich distribution for all other vaccines. However, the benefit had less pro-rich distribution compared to the utilization. And next slide, please. And in summary, the wealthier households disproportionately benefited from the publicly financed EPI program than poorer population. This is mainly because the wealthier family had higher vaccine uptake. And IDCC provide the robust information on the average vaccine delivery cost, which we then adjusted with the regional, urban, rural delivery cost variation for Myanmar. And next slide, please. And this slide shows the unit cost across different regions and states, urban and rural area. And the slide is a bit busy, but I want to point out the delivery cost in the second column. And the delivery cost, in some area, delivery cost is the same for both urban and rural area, but most of the area, the delivery cost is higher in the rural and the lower in the urban area. Next slide, please. And next slide, please. Next, okay. This slide shows how we use the IDCC average vaccine delivery cost in our study. The first column shows the total operation cost for the different areas in Myanmar, and we calculated the average cost, and then we estimated the percentage increase and decrease relative to this average cost. The third column shows the operational cost for the IDCC, that is average cost, and then we applying the percentage increase and decrease, and we got the vaccine delivery cost that is vary across different region, urban and rural area. So in Myanmar, the wealthier family usually live in the urban area, which had lower vaccine delivery costs. Even with this cost variation, our findings show that distribution, the benefit distribution is still pro-rich. That indicates that the wealthier family, there is a huge disparities in the service use. So that is next slide, please. And that is the end of my study and my presentation. This study was done by the Community Partner International in collaboration with the Duke University. Thank you very much.
Great, thank you, Sinmar, and thank you to all of our speakers for your excellent presentations. With that, we can move straight to the question and answer session. So, as we said, please type any questions in the Q&A box below, and we'll get to as many as we can. So we had a question from Abraham Wondemu Dagne from the International Agency for Research on Cancer in Lyon, and he had a question for Charles. So Charles, in your static Markov model, how did you account for the impact of vaccination on the incidence of rotavirus-related disease over the 10-year period you were studying it in Nigeria?
Oh, thanks, Abram. That's a very good question. So we try to avoid overassumption in the model. So what we did first of all was to look at the effect of the vaccination on the incidence for a year. So as we know, there's a waning effect of the vaccine. So over the 52 weeks in a year, the vaccine effectiveness dropped. So we modeled the vaccine effectiveness, on a weekly basis as it dropped down to 52-week incidence over a 10 years because we're not sure by what percentage it's going to actually reduce. So it was it was a static model, as he said, not a dynamic model, but it just gives us an insight. But we did apply the discounting effect. But the effectiveness we used on year one of the vaccine was what we used on year two. And this was actually similar to other rotavirus studies we found in the literature, which were also published in the Lancet over the years.
Great, thank you so much. So a question, perhaps George, you could have a go at answering this. So if you could just explain how the economic and the financial cost perspectives differ when looking at immunization costing.
The difference is that financial costs usually are fiscal costs that needs to be borne out of the budget, state budget, or the program budget in order to cover the certain recurrent or capital costs. But economic costs are those ones that are incurred on top of the purely financial expenditures, and those could be the volunteer costs that are being contributed to the program delivery if there is a outreach strategy or any other cost that are necessary, does not necessarily require the funding or financing out of the budgets, program or state. That will be my simplified definition of the financial and economic costs.
Great, thank you. And a two-part question for Zin. So first of all, how did you measure benefit of vaccination in your study? And what factors did you take into account when adjusting for the cost for different regions? Are there any differences considered across different wealth quintiles?
Yes, for the first question, yes, we calculated the benefit incidence analysis by multiplying the immunization usage. That usage will be different across the region and urban and rural area. So we multiplying usage with the immunization cost, that is the cost per unit, and that will be different across the region and urban and rural area. So, and then we calculated the concentration index by using the Quine index in the starter. So, so that is how we did for the calculation of the benefit incidence analysis. And another question, can you remind me another questions?
Sure. So it was what factors are taken into account while adjusting the cost for the different regions?
Okay,
and
yeah.
were there any differences across different wealth quintiles?
Yeah, because can you show me my slide for the last slide? Yes, we only use the operational cost that is different across the region and urban and rural area. That is from the previous studies done by the other people. And then we calculated the average cost and then we applied the percentage adjustment of based on the average cost. And then we applied this percentage to the IDCC cost. Actually, this study was done by the previous person and the other person, and then we used that operational cost that is different across the urban rural area. And then, as I mentioned earlier, the people, wealthier people tend to live in the urban area, which has the lower vaccine delivery cost. So that show the different result for the different well quantiles here.
Great, thank you. And a question perhaps for Charles from Nabil Atif. So if the model inputs for a lower middle income country are not available, for example, Pakistan, for which most of the data is missing, which sources can be utilized to put in a Markov or any cost-effective analysis model?
Okay, for what we can do here, so this is where the weighting system comes into play. So even if there is no cost for Pakistan, what we need to do, if you look at the IDCC cost catalog, you're going to find several studies, maybe a couple of them, that have actually introduced the vaccine. So if the weighting system is applied, so the weighting for the country that is on IDCC, if you apply the weighting properly, it's not going to be the same with the Pakistan. So all you need to do is the final weight you get is actually what you're going to, it's sort of a cross multiplication of what the vaccine cost for that country with the weights compared to the weights of your country. That's the reference country to the target country. And then that gives you the cost for your country. And then I think there's a question Flavia also asked regarding the difference between why is Rotarix actually more expensive in terms of Rotavax more expensive in terms of immunization delivery, regardless of the fact that it has a lower volume. So in terms of the immunization delivery, there are several factors that affect the costs. Number one is the number of doses, as we saw in the mapping. So if you have a vaccine that you need to give up to 3 times, so it's like saying you need 3 staff or 3 different times of the healthcare worker to come. And this is a human capital cost. So it's going to impact on that. Although it is about 26 CMQ, but the human capital cost was actually very significant compared to the cost of the volume. So the mapping system explained that, but I can say that the number of doses was a big factor. And regarding the introduction of the vaccine in Nigeria, actually Nigeria introduced the Rotavac. And there is a clear reason for that. As I said, there were a lot of factors that could affect the immunization delivery costs in Nigeria. And if these measures are controlled, the costs can come down. We can see that the wastage for the Rotavac was very high. And this wastage was what was estimated from the WHO wastage calculator, which was about 50%. So, and I believe that the country can reduce this wastage. So if this wastage is controlled and some other factors, then it is very possible for Rotavax to be to be the cost-effective choice. And there is something we need to take note. There is a difference between something being cost-effective and something being feasible. An intervention could be cost-effective, but it might not be feasible to implement. For a system like Nigeria, transitioning from Rotarix to Rotavax is not very possible. There is going to be a very huge wastage. And I tell you, if we are transitioning, you're going to have some excess or leftover of Rotarix, and then you bring in Rotavac. And you cannot give someone first dose as Rotarix, and then you want to switch to Rotavac. So you find out that what the country is going to spend for switching will be even more than what they are saving. So, but what we presented here was not implementation science. It's just purely a cost effectiveness analysis. And I believe there are a lot of WHO experts in Nigeria, and Gavi also advised Nigeria. So looking at this from an implementation perspective, I would recommend Rotavac to be used, and that is what Nigeria used. So I think they're on track.
Great, thank you so much, Charles. Well, that's us already at time, unfortunately. But we want to thank all the presenters for their amazing presentations. We got some more questions you didn't have time to respond to, but our presenters will send their responses later on, and we'll also share the recording and slides as we mentioned. But again, a big thank you to everyone who presented and everyone who attended and asked questions.